Our next speaker is Dr. Nidhi. She'll be talking about VEP. In most of the places, if they are doing electrophysiology, the VEP is always there.
Good morning, everyone. Thank you, sir, for making me a part of this IC. I have no financial interest. Now, VEP measures the electrical signal generated at visual cortex in response to visual stimulation. The occipital responses corresponding to the central visual field are measured, and it assesses the intracranial visual pathways and their functional integrity right from the retina to the optic nerve, optic chiasma, optic radiation, and occipital cortex. Now, the peripheral retinal projections are within the calcarine fissure, but the central retinal projections go to the occipital lobe. The foveal projection is magnified at the cortex, and at the fovea, the linear extent of the cortex is around 5.6 mm per degree, while 10 degrees away from the fovea, it becomes only 1.5 mm per degree. So what are the indications of VEP? Optic neuritis, multiple sclerosis, optic atrophy, hereditary optic neuropathies, toxic neuropathies, traumatic brain injury, compressive optic neuropathy, glaucoma, amblyopia. Additionally, it helps us to evaluate any unexplained visual loss, malingering, pre-surgical evaluation and prognostication of cases, and measuring the visual acuity in non-responsive subjects. So the requirements here, we'll have an active reference and ground electrodes having impedance less than 5 kilo ohms. The active and reference electrode impedance difference should be less than 20%. The placement of the electrodes follows the 10-20 rule, in which the whole head is divided from the nasion to the inion in different parts. The active electrode is placed at OZ, the ground electrode is placed on the top of the head, and the reference electrode is placed at point FZ. Now, this is the recording interface showing the difference in resistance impedance between the two electrodes is not okay. Now, the stimuli of the VEP can be flash, pattern, color, or motion. Most commonly used in flash VEP, we have the Gansfield stimulator, and in pattern VEP, we have the CRT monitor. Now, pattern VEP is the most commonly done test done in patients having good visual acuity. The patient should be light adapted and sitting at 100 centimeter with correction done. Pupil should be undilated and has to be done monoocularly. Flash VEP indications are same but done in patients who have poor visual acuity. The eye is light adapted, dimly illumination, the room should be dimly illuminated and done monoocularly. Pattern onset and offset I'll be talking on later. For pattern VEP, the requirements, we require a checkerboard pattern. Here the pattern is reversed and we have different checker sizes, 60 minutes or 1 degree and 15 minutes. The luminance has to be constant and the contrast needs to be high. In flash VEP, it should correspond to a field size of 20 degree and at least one flash per second, that is 1 hertz. Flash intensity is low, 1.5 to 3 candela per meter square, and the background intensity is also 15 to 30 candela per meter square. Now, pattern VEP is done for investigation of optic neuropathy. Additionally, flash VEP will be done in patients having poor optics, poor cooperation, poor vision, and where pattern reversal cannot be done. Pattern onset and offset VEP is done in patients having nystagmus, malingering, or amblyopia. Coming to pattern VEP once again, this is the checkerboard stimuli. The pattern is reversed, alternate black to white and white to black. And we have to look at the artifacts like blinking of eye, the lesser the better. The total number of tests done at least should be 64, and these tests are repeated at least twice. In infants or patients having less attention span, the number of tests per test can be reduced. Now, the check sizes subtending 15 minutes of arc are the best stimuli for testing foveal vision. And checks of 60 minutes or 1 degree are superior in evaluating the parafoveal vision. Therefore, using more than one check size increases the diagnostic yield. If the resulting VEP using the larger check is poorly performed, then we have to use again a larger check than that or use a pattern onset stimulus. Now, this is the waveform that is seen. The most important wave here is the first positive or P100 wave. The amplitude of the P100 is calculated from the trough of the N75 to the peak of the P100, which should be more than 5 microvolts. And the latency is normally from 90 to 110, varying from lab to lab, but on an average is taken as 100. And this is how the report is given to the patient. Few examples of pattern VP. This is the normal waveform in both the eyes, showing normal latency and amplitude. This case is that of a traumatic optic neuropathy in left eye. There is delayed implicit time and reduced amplitude versus the right eye. In cases of AION, the implicit time here is normal, amplitude is reduced, and the waveform has become wider. Optic neuritis in the right eye, there is a delayed implicit time versus the left eye and moderately reduced amplitudes. This is a case of optic atrophy with no PL, and no signal in the left eye could be elicited. Now, a VEP can also be used to measure the progression of optic nerve gliomas in cases such as neurofibromatosis. There will be increase in the latency of P100 in both the optic nerves with progression of the gliomas. In cases of toxic neuropathy like ethambutol toxicity, here the latency of P100 will be increased. Coming to pattern onset and offset VEP, here the pattern is flashed on and then off. So 200 milliseconds it's on, followed by 400 milliseconds of off equiluminant diffuse background. Here also we will have two check sizes. The pattern onset or pattern flash stimuli produces a more robust VEP than does pattern reversal in the central 30 degrees. And this is the comparison between pattern onset offset and pattern reversal. Here, first it is on, and then there's an offset, and in reversal, the checkerboard pattern changes from black to white or white to black. Now, pattern reversal stimuli usually exacerbates nystagmus and interferes with the ability of the eye to maintain foveal fixation. Thus, this is better in testing patients having nystagmus. Pattern onset stimuli can also be the most productive stimulus for monitoring amblyopia. Pattern onset stimuli is less sensitive to poor fixation, eye movement, and deliberate defocusing using, thus it is useful in examining patients that might be malingering. So this is the waveform. Here the second wave or C2 is the most important, which might have a latency of 100 to 120 milliseconds. Flash VEP, here the stimulus is a flash. Field side should be at least 20 degrees and 2 measurements need to be done. Indicated in uncooperative or unconscious patients having media opacities, prognosticating of eyes with poor vision before planning any surgery, and monitoring the visual function of babies. So VEP is often prognostic in delayed maturation of the visual system. Usually the infant with delayed maturation has a normal flash VEP, whereas permanently cortical blind infants might have abnormal VEPs. This is how the recording interface looks, which needs to be enlarged according to the voltage. Here, the P2 latency is most important, which is 100 to 120, and the N2P2 amplitude should be more than 10 microvolt. Just a note on sweep VEP, to be done in infants, suspected malingers, or disabled subjects. Here, the visual acuity is extrapolated in logmar units. Multifocal VEP are not that commonly done. Here we have 4 active electrodes in a mounting bracket, and they give corresponding waves, which can be in a sectoral pattern or a ring pattern. This is the normal multifocal VEP in both eyes. Right eye is red, left eye is blue. In optic neuritis, if you see, initially the red is extinguished in the center and abnormal in the central 30 degrees. And over time, there is significant recovery in the amplitudes, but slower peak times due to demyelination. This is the output in unilateral glaucoma. Just reviewing all the waves of all the VEPs. That's all from my side. Thank you so much.
Thank you, Dr. Nidhi.